Hello, everybody. Welcome to week 3 of your second year of respiratory therapy school. So your fourth semester, one more semester to go after this. And kind of as I explained the other day, um, as this month we're entering the longest month really of the fall semester for what you have left because of the way the fall break's going to fall in October, the way Thanksgiving comes around in November, and then the semester's cut short for the Christmas break or the winter break in December. So thus far, we've covered pulmonary function testing in week 1. We also did some bedside spirometry review going over the normal spirograms. So we've covered that in the very first week. Last week, we did laboratory analysis. So remember, continue going over what it would be encompassed or involved with incorporated with a CDC, looking at the differential of your white blood cell count and so on and so on, platelet hemoglobin, uh, the importance of assessing those individuals, especially when you look at the coagulation factors, if you're going to perform any type of arterial stick on those individuals. Remember, we've got indications for procedures that we do. We've got contraindications and procedures that we do. Of those contraindications, you have relative and absolute contraindications. So absolute contraindications, under no circumstance should you do that. Relative contraindications, yes, there are reasons why you shouldn't do it, but there are also reasons to support doing it for the benefit of the patient. So we'll keep that in mind. And then this week, uh, I know you all listened to me talk all day the other day about the graphics, so I won't be overly verbose in this, but the ventilator graphics are going to be important. You'll need to know those not only for your career, but testing purposes, obviously coming up. So remember the 3 different scalars that we looked at: flow time, volume time, and pressure time. When you're looking at those graphics, you can remember the shapes of your waveforms as well, whether you got sine waves, square waves, or constant waves. And then you have your ramp or decelerating waves that can be included as well. There's also characteristics of each of those waveforms. Remember, with each of those, we talked about how to determine if a patient might be flow hungry or if they're being flow starved a little bit, where you might need to do this. So you remember to look for the dip in the pressure waveform when we're doing that. You can also determine by looking at your ventilator graphics if there's water in the circuit. Hopefully, you don't have to look at the ventilator graphics to know that there's water in your circuit, but you certainly can do that. So we're trying to build the overall picture for how you can do a proper assessment on your patient. But remember, the most important thing that I said the other day, or I feel like it's the most important thing, when you walk into an ICU room, you've got a ventilator that's got nice graphics, nice numbers on it. You've got a physiologic monitor that's got ECG rhythm showing, may have your respiratory rate on there, your pulse oximeter, your pleth for your pulse oximeter. You've got an arterial line in, you may have that. If you've got hemodynamic monitoring capabilities, you may have you may have a pulmonary artery catheter or a central line tracing that you're looking at. Depending upon what else might be in the room, you've got IV pumps that may be going off here, different lines going here and there. May have an intra-aortic balloon pump, may have inhaled nitric oxide therapy running. So there's a whole mess of stuff that can be going on in the room. And you can get caught up in trying to analyze each of these rhythms and so forth, or each of these artifacts or graphics that we have. And that's good. You should do that. However, don't forget that there's a patient attached to all of that stuff. So we want to make sure that we don't fall into the trap of treating a monitor rather than the patient. Make sure that you are treating the patient and not the monitor. The monitors will give you good ideas of what's going on with the patient, but don't forget that there's a patient attached to that. For instance, you walk in and you see the ventilator graphic on your volume time waveform that indicates that there's a pressure, that there's a leak, a volume leak in it. Well, you don't want to spend too much time because if there's truly a leak and it's significant enough, patient's not going to be breathing. And if the patient's not breathing and they don't breathe long enough, then they're not going to be living. So you want to make sure that you're attending to the patient that is attached to all of the equipment and sophisticated monitoring that we have available for them. So remember, in addition to those graphics, we also looked at our loops, our pressure volume loops, flow volume loops. We also looked at different curves and what have you, how a decrease in compliance might affect those pressure volume curves, how a decrease or an increase in compliance could potentially affect those curves as well. In addition to the flow volume loops, we looked at the difference between a spontaneous breath versus a positive pressure breath. So make sure as you're studying, you can remember that. Whether or not the loops go in clockwise motion, depending upon if it's a spontaneous breath or a positive pressure breath, whether they're going in a counterclockwise motion. We also determine how to determine if it with a loop, if it is a spontaneous breath, an assisted breath, or a all-out mandatory or positive pressure breath. So make sure that you can do those as well. And we said that you can look at air trapping or auto PEEP, intrinsic PEEP, aqua PEEP. All those mean essentially the same thing. Whether or not you have a leak, um, and ultimately you're trying to gauge synchrony for the patient when we do that. So you guys can review the items that we had gone over the other day. I didn't want to pull up a bunch of waveforms because I know you all spent the time listening to me go over that in class the other day, but I did want to touch base on that for a brief period of time. Next week, I'll try to spend a little more time going over what we have on tap for. So next week, we'll be talking about the overall assessment of respiratory function, and then we'll move into the improvement of oxygenation. So that's where we might start talking about optimal PEEP and things of the like, and making sure if you're going up on PEEP, you've got the FiO, or if you're going up on FiO2, you bring the PEEP up to support it, and also making sure that you're not putting too much positive expiratory pressure in the chest where you begin to have a negative impact on the overall cardiovascular status of the patient, or hemodynamic status of the patient. So those will be some things to come. And I'll try to have some more things for us to look at and review. But I did want to provide a brief overview of everything that we had done this week, and that pretty much wraps it up. I mean, obviously, we did that in a lot more detail during class. But nonetheless, thank you all for your continued hard work. And I'll see you all next week with a review of the information that we cover in week 4 of year 2. Thank you for your time and attention. I hope you all have a good day.